And there was this whole qualification of you should consult your doctor and every one of your relatives and everybody else before you have a PSA test drawn, because it might lead you to having tests that might be negative for cancer. Most ridiculous thing I've ever heard in my life. And as a physician, I think this stuff is crazy. Okay? How long did it take, and you guys grew up in a society where you had to just about force women to go into the doctor's office and get an exam to have a pap smear. And that came about. George Papanicolaou was the doctor that invented the pap smear, and then you went ahead and you can point to, I'm sure, a number of cases of people you know that had cervical cancer that it was found by the pap smear when they were asymptomatic, they were not symptomatic. Well, just we have arguments about this with the gynecologists now, because the gynecology societies have come out and said that you don't need pap smears for certain lengths of time now. They're saying people over the age of, I believe, 65 don't need a pap smear for 5 years in between. Personally, I think these people are out of their minds. Okay? Screening for cancer is the best thing that you can do for somebody. Finding that cancer early is again, the best thing you can do for somebody, because and I feel that's our job as family practice people, as primary care people, OB-GYNs and the other associated entities. That screening is so important. To find that cancer early, nip it in the bud, and then you're not treating metastatic cancer. You're not treating cancer that's spread. So that's what's so important about melanoma, okay? And again, numbers are steadily increasing because people are out in the sun, getting suntans, and let's go to the next one there. And the risk factors. Okay, so the risk factors, and what we don't realize, we take our kids out to the beach, and we take them out to the pool, and we take them out to the lake, and maybe we don't put enough sunscreen on them, and they burn, and we say, oh, you'll be all right, and we rub stuff on it, aloe vera and all this stuff. They're saying that people encourage severe burns in childhood appear to be at much higher risk for melanoma. And where's my thing that says if you have, I think it's 3 to 5 severe burns in your lifetime, really multiplies your risk of melanoma and any type of skin cancer. So if we think back to all the fair-complected people in this area, just sitting here in the room, I bet you've had sunburns that were bad earlier in your life. Part of my family's my wife's pretty dark, so I have a son and a daughter that's pretty dark, and then I have a son that inherited my skin, which is pretty light, and he always burns. So, you know, we're going to have to watch him for something in the future here. So, highest risk populations seem to be individuals with fair complexion who receive intermittent doses of radiation, resulting in severe sunburn. And of course, we've got one of our nurses in the back here is a redhead. The redhead is a couple of nurses that are redhead. Your redhead is the worst risk because they've got the fairest skin. The blondes are next, and then the darker haired people, etc. And that's nice to be able to say that. I have a very good friend who's a sun worshiper. He was always in the sun. I don't think he really used blocker. He's of Greek descent, so he's a pretty dark guy. Pops up with melanoma. And I sent him for a lesion on his back to the dermatologist. He's a patient of mine and he's a relative also. I sent him for a lesion on his back. Lesion on his back didn't end up being melanoma, but the astute dermatologist he went to over in Newcastle, Pennsylvania, noticed that he had one under his eyelid, under his eyebrow. And sure enough, that was positive for melanoma. He had to have a large resection of that area. He's still upset about it because he's 75. He's really vain about his appearance, which is great. But an eyebrow really kind of goes up in the air now. But he's done with the melanoma. He's had 2 types of cancer. His other cancer was positive prostate cancer, and we diagnosed that with a PSA blood test. He had a PSA normal score. His PSA was 53, okay? And we had caught that cancer before it spread from the capsule. It was an aggressive cancer. It had taken up his whole prostate gland. This is 15 years from that. He's still alive, just from that simple blood test. So we've got the ABCDs of melanoma. We're not going to spend a lot of time on that because I do have a chart, and the chart is in your handout, and the chart has this ABCDs of melanoma on it, but just to go through it, asymmetry. So you see the mold here is symmetrical, But that mole right there is asymmetrical. In other words, it's growing in different directions. The borders of a melanoma are uneven. Okay? And the color. The colors, usually there's multiple colors. That's called variegated. And there's multiple colors in the melanoma compared to one color in the mole. So that's why a lot of times doctors pretty much use this same thing. Can you go to the next slide? And they pretty much use this same idea when they're looking at your moles in the office. And you know, we can look at moles pretty quickly, and that's why everybody says, well, that dermatologist, he was really fast with me. There's a dermatologist in Youngstown right now, Boardman, who's a great dermatologist, great doctor, has been in practice for a million years. He usually he usually is very aggressive about these skin cancers. And the old doc's story is that the lady was in, and he says, yes, that's a skin cancer on your face. We should take that off. And she says to him, well, I'd like to think about that. He gets up, walks to the door, turns around and says, was that long enough? And he does a high-volume dermatologist, an excellent dermatologist, been in practice for 50, 60 years up in Boardman, and tremendous guy. So then we go with diameter of the melanoma. Larger in diameter, size of a pencil eraser, but they can be smaller, they can be bigger when they're detected. And the point is they're changing. They're evolving. Any change, size, shape, color, elevation, you should be running to the doctor with them and checking. Now, I have a lot of people who have fair skin, and they go to the doctor, the dermatologist, every 6 months for screening to see whether there's changing moles and everything like that, so they can catch these early. Okay? So the precursor to these, the lesion you get before the melanoma, is a dysplastic nevus, and dysplastic nevus looks like a melanoma. If you see here, it has the shape changes, it has some of the coloring situation, and a lot of times the doctor will take a mole off saying, I think that's melanoma, then it comes back and it's really this dysplastic nevus. But that's okay. You got a lot of skin, and to remove that is worthwhile because you'll be catching it if it's a melanoma early. Now, a lot of people, when they have melanomas removed, the number of dysplastic nevus have a lot more chance of developing melanoma because they have the tendency for these moles to change. So go ahead to the next one. Okay, so we're going to, one other thing about the melanomas and everything is that if you're seeing any kind of changing mole, that's what I would do is run into the doctor. Your family practice is a good place to start. He's seen over and over again what skin cancers look like and what melanomas look like, and then he can refer you on to the appropriate person. Now, the surgery involved in the melanomas, they do remove the lesion, but most of the time they have to go back. Sometimes you have to go to a plastic surgeon, sometimes a general surgeon, and they will remove a large swath of skin there. There's certain criteria for thickness on melanomas. We're not going to go into the big details on that, but melanoma thickness goes by millimeters. And millimeters, very, very small measurement. And if it's thicker than 1 millimeter, then the melanoma has to be considered intermediate and possibly spread. If it's thicker than 4 millimeters, which is a very small measurement, it's a very small measurement. If it's thicker than 4 millimeters, that's considered a possible metastatic melanoma, and you have to be checking lymph nodes. And with most of these, they are checking lymph nodes anyways, but depending on the depth of the melanoma is how much work you have to do in checking lymph nodes and going ahead to see if there's distal, or to see if there's organ spread anyplace else. And organ spread in melanoma right now has a lot of emphasis in cancer treatment. Basically, it's treated with chemotherapy and the new, some of the newer medicines out, the interferons, and some of the new medicines that are putting out by some of these companies that are being developed right now. Melanoma is a big issue in that chemotherapy. And I don't get into cancer chemotherapy. I have too much to keep me busy on the other stuff. That's why there's specialists in that, and it changes. But we really have a great cancer system in this country, and a lot of people don't realize it. The effects of these chemotherapy agents are constantly being reported in journals. doctors are watching these journals, and most doctors have a protocol that they follow. So you'll go into, I know Dr. Knight in Poland area over here, at one time he was following the Southwest protocol. Other people follow the Southeast protocol. Other people follow the New York protocol. But there's 3 or 4 different protocols, 5 protocols in the country, and they'll follow that protocol. So they stick, a lot of these oncologists stick with one set of protocols where what I mean by that is that the chemotherapy regimens are devised by a group of doctors, and they put that out as their protocol, and that's what they use. And so they stick with that. Now, can they go to other ones? Sure, they can go to other ones. If there's promising information, they go to that. But most docs will use a defined one set of protocol, and that's what they follow throughout their cancer chemotherapy progress. And there's so many different things going on with chemotherapy and so many things being experimented with. I can't possibly keep up with that. It's hard enough for me to do the primary care and everything else. So when I refer somebody, I do read the journals and I see, oh, well, this had great luck with melanoma, this had great luck, but I don't keep track of every chemotherapy. I can't possibly do it. So we're moving on to the other types of skin cancer now, the basal cell and the squamous cell. Now, basal cell, most frequently occurring skin cancer. So that's important. This is the most frequently occurring skin cancer. And again, abnormal, uncontrolled growths or lesions that arise in the skin's basal cells, which line the deepest layer of the epidermis, which is the outermost layer of the skin. They look like open sores, red patches, pink growths, shiny bumps, scars. Most of the time people come in and they say, well, there's a scab that forms there, and I kind of scrape the scab off, and then it clears up a little bit, and then another scab forms, and those are most of the time basal cell cancers. They don't, for the most part, spread any place but in the skin, but I've seen some very aggressive local basal cell cancers, and they can appear really unusual. So I'll tell you about a case that I had. This was the most unfortunate local guy, and Willie, I thought, it was early when I was in practice, I thought it was a sebaceous cyst. We removed the sebaceous, what looked like a sebaceous cyst. We took it off. That's a little cyst that's in the skin. Here it was a basal cell cancer. Came back in, unfortunately, waiting much too long, because he said, well, it didn't heal up. I said, well, where have you been? It came back in like 6 months later, and this thing is large. And here it wasn't a sebaceous cyst. It was a basal cell cancer. We tried to get him treatment. It was a very aggressive basal cell cancer by that time. He had let it go much too long, and it was bad. So the thing is that these things can masquerade as other things. They can be different than what you think they are, but that's why you need to consult the doctor most of the time. The doctor will either remove these himself, and there are some family docs. My partner, Dr. Dombrowski, one of my partners, he removes, has done a number of skin cancers himself. He did a partial surgical residency before he did his family practice residency. He likes to do that. It's okay with the patients. They usually, if he finds a melanoma, they have to have that big resection anyways. So he does a lot of those. A number of different doctors, family practice, will do the squamous cell cancers. A lot of the doctors do the actinic keratosis. I don't mess too much with that. I send most of them on to the dermatologist. Then the second, this would be the third type of skin cancer is the squamous cell carcinoma. Squamous, squamous, whatever way you want to pronounce it. Everybody in medicine pronounces things different than they were supposed to be pronounced. There's doctors that have pronounced these all kinds of different ways. So, but I say squamous, squamous. Anyways, and then it's a rapid growth of keratin cells in the skin's upper layers called epidermis. These appear red or pink areas called actinic keratosis. Can also look like red scaly patches, open sores. May occur on any type of the body. It can be in the mucous membranes. It can be inside your mouth. It can be in other places. It can be on your genitals. But it's most commonly in areas that are frequently exposed to the sun. Again, so unless you're a nudist, the areas that are covered up are usually not exposed and do better. But you can find them anywhere. So the risk factors, again, the same risk factors. People that have fair skin, light hair, blue-green eyes, gray eyes, history of substantial sun exposure, which, unless you really try to get the sun around here, You don't get a little sun exposure just by walking around, that's for sure, in this area. But there's ultraviolet light coming in anyways, even though there may be clouds, so you're exposed. Anyone that has the basal cell is most likely to develop a squamous cell, and squamous cell cancers are twice as frequent in men as in women, and I don't know why that is. They rarely appear before age 50 and seen in individuals in their 70s. Well, these are the things a lot of the farmers get, especially so we see a lot of those areas, a lot of these cancers around here. We have a lot of people that spend a lot of time outside. A lot of people in this area have grown up in farms, especially like the Damascus area too, where we have our other office, a lot of dairy farms and that kind of stuff. So they're always out, they're making hay, they're always out in the sun. Maybe they didn't wear hats, they didn't wear sunscreens. So additional skin cancer development risk is estimated to be 35% in 3 years and 50% in 5 years after the initial diagnosis of the squamous cell or the basal cell. Any changing skin lesion should be checked. So I think that's real important. We've given you the facts on the skin cancers, what different kinds there are. It's a much broader topic than most people think. And just to review, melanoma, the squamous, the basal cell. We used to do a lot of follow-up on squamous cell carcinomas, on squamous cell cancers. It used to be when we diagnosed squamous cell cancer, they'd make the person do a chest x-ray every year. That's kind of gone out of fashion because they can metastasize, they can spread, the squamous cell cancer can spread to other areas. The basal cells usually stay right where they are, and the melanomas, we pretty much described that. So what do we do for prevention? So again, most skin cancers could be cured if found and treated early. Again, screening early. Personally, and I say this in all my talks, I'm very, very, very disappointed in the medical community in research. Okay? So they might not like me saying this, but I'm very disappointed. I thought by now, I've been in practice 36 years. Like I said, I'm only 42, but I've been in practice 36 years, and at this particular point in time, I really, really thought that by now you'd be able to come into my office and I say, hey Joe, I'm going to do your cancer screen on your blood, and then I'm going to check you for prostate, colon, pancreas, this, that, the other. And there are some of these markers. The insurance companies have barriers to doing some of these markers. You really don't do these as a workup to screen people for cancer. Most of the markers that are in the blood you do to follow people with cancer to see if their markers are going up and down. The only real screening test right now in the blood is the PSA, and then the screening test for the ovarian cancer. It's not used anywhere near as much as it should. The PSA is the ovarian cancer test is not used anywhere near as much as it should. I thought by now there'd be a panel, especially breast cancer, with all the money that's being put into breast cancer research. I thought we'd have a screened blood test by now for that, and that you'd be able to walk in, you get your screening panel, and we say, well, you have no markers for these cancers, so you don't have to worry. But instead, we have to go through mammograms, which I absolutely recommend. I don't recommend the new recommendations where they're saying, don't get a mammogram for 3 years when you're older. We see breast cancer in older women. We see breast cancer in younger women. We do see breast cancer in women under 40, actually. I don't recommend a lot of screening mammograms for them, but we do see it. It's bad when they get it premenopausal. It's not good when they get it postmenopausal, but it's much worse at premenopausal breast cancer people. So I'm a big believer in screening. I believe as much screening as you can do, the better off you are. And I believe the older protocols are pretty good. They can be amended a little bit, but the time that they're talking about in between mammograms, in between pap smears, is just ludicrous. It's craziness. So I recommend you do as much screening. Listen to your doctor. They seem to know best, but we have a running battle with the gynecologist because they're examining people and not doing pap smears. So I told them, make sure they send them to me because I'm going to keep doing them as long as the insurances and Medicare are paying for them. Now that's going to be the problem because these insurance companies and Medicare are looking at these task forces that they put together, and they're saying, well, it's not economically feasible, so we're going to stop paying for these things. And that's a disaster in our society. That's really a disaster. You're going to see these cancer rates go up much higher than what they were before. So anyways, best time to do an exam on skin cancer, best time to do the exam is after the shower or the bath. You know, you don't have any clothes on, you've got mirrors in your bathroom, check them out, check your skin in a room with plenty of light, use a full-length mirror. You don't have to do that after every shower. But you might want to do it once a month, where you say, you know, I'm going to check my skin once a month. I did it in July. I'm going to do it in August. I'm going to do it in that. Is there a new mole? That kind of stuff. Use a full-length mirror, handheld mirror. Check yourself from head to toe. And that's easy to say. I'm going to tell you, look at your partner's back. Look at your kid's back. Okay? That's what they told us in medical school. Make sure you examine your patient's back. And that's still the biggest thing, because you can't see your back for the most part. And most people don't have mirrors all over. I sure don't. I don't want to see any of that stuff. So I don't have mirrors surrounding myself in the bathroom. I don't have that much stuff. I got to look with a special mirror and get on an angle to see my back. So the thing is that many people have spouses. If you don't have a spouse, maybe you have a friend or something, and they say, hey, take a look at my back, make sure everything's all right. Or you're in for your doctor, and the doctor maybe is just doing a cursory exam. Say, hey, doc, is there anything on my skin? Suggest it to him. Make it suggested. Maybe he's not thinking about that. Maybe his stockbroker called and his coffee stock went down, or something happened in his life, or his kid called and said, hey, you know, they're throwing me out of school this week. What do I do? That happens a lot. So the thing is that it's best to mention it to the doctor if you're in there. Take a look at my back, because you can see everything else pretty well. If you have a spouse there, it's a good idea. Take a good look at the spouse's back. They have moles. They have things like that. Get them checked. Check for anything new mole, new red or dark area. And people come in with all kinds of things. What's this, doc? What's this, doc? What's this? That's okay. Hey, the one thing you come in that's cancer, you'll find it. So keep looking, keep checking. And a sore that does not heal is very important when you're talking about skin cancer. It's extremely important, because that's most of the time a skin cancer. If you have a sore that doesn't heal, you've got to get into the doctors and check. Now, we have a body mole map, okay, which is one of our handouts. And we found this, I don't know where we found it, maybe on the internet, or I might have found it somewhere else, but it's a body mole map. It basically describes what we're talking about here, and you can find it on the internet. Just look up, if you guys are internet prone, go on Google, and I'm not the best guy with the computer, but go on Google, just put in body mole map. Now, I hope you don't get some kind of crazy website, but you might. Anyway, so look at the body mole map. We have the handout here, and it talks about the ABCs of melanoma, and it gives you a lot of skin cancer facts. And then sunscreen. Okay, so it's SPF of at least 15. The stuff I read says that above 15 really doesn't protect you all that much more. I know on my face when I go out in the sun, and we do like the beach, and we like to go to sit out on the beach and that sort of thing when we're on vacation. I use like 45 on my face. But all the reading that I says that above 15, you're not really getting much of an effect out of that. But I would use the highest sunscreen you can for different areas, especially if you're prone to this. Now, that's the other thing. If you're taking any medicines, and if you're taking any antibiotics, if you're taking anything new or anything old, check it out. Because most of these things that you take, many of these medicines that you take, can increase your chances of sunburn. I just had a patient in yesterday, thank goodness I didn't prescribe it. The patient was on doxycycline. The patient has a very severe skin problem with some other type of skin thing going on. He just was the subject of grand rounds at university hospitals, so they can't figure out what's going on his skin. They give him doxycycline for an infection. Don't say anything to him, but this might create some sun sensitivity. He goes out, and sure enough, his legs became all blistered up and everything like that. Of course, he had the underlying other skin problem, but sometimes we as doctors don't warn people about these things. But medications, antibiotics, I had a person once that we put on one of these medicines, and he did say he was going to did not tell me he was going to the beach. And of course here you don't get that much sun exposure, but he's going to the beach. Put him on one of the medications. Just driving to the beach, he had his arm outside of his arm. He got these terrible burns. It's not funny. He got these terrible burns on his arm. Okay, my arm's all burned. Well, what did you do? Well, he had that arm out the entire time he rode down to the beach. and had it exposed to the sun. And just that was enough with the antibiotics that he was on to cause burning. So it's serious and it's bad. It can happen. Wear a hat, protective clothing, eyewear. I don't know about you guys. I like to sit out on the beach, but a lot of times I just cover up. I wear my shirt, I wear my not pants, I have shorts on usually, but I'll put a blanket over me. I just sit there. I like to sit there. So cover yourself up, skip the tanning bed. Again, they used to say that the tanning bed was okay. It was UVB and UVA was bad for you, was the ultraviolet from the sun, and UVB was okay for you. But most doctors have come to the conclusion tanning beds are not a good idea. It's exposure to, say, ultraviolet type of radiation. Be careful of the reflective sunlight. A lot of times people will sit somewhere and the sun will be reflecting at them. They don't think that's effective because it's coming off of something. It's still very important. 5 reasons you should always use sunscreen. Your skin needs protection from the harmful rays. Sunscreen is proven to reduce the risks of skin cancer. Use sunscreen. Sunscreen prevents facial brown spot, reduces the appearance of blotchiness, slows down the appearance of wrinkles, and other types of premature aging. And some of you people use a body lotion or a skin lotion. A lot of those have sun protection in them. Buy one that has sun protection in them, and it's a body lotion at the same time. That's a good thing to do. So that's about it. I think we covered that pretty thoroughly on the skin cancer. I'm happy to answer any questions you might have. But if I can leave you with a thought, get screening, any changes in moles, etc., and pass this on to your children. Pass it on to your friends. Pass it on to your spouses. This is an easy topic to talk about. There's nothing personal with it, and it's a great thing to suggest. That one suggestion, putting into their mind, may really change their whole life. We had a person in, not that long ago, he came in, I don't know if you watch Seinfeld at all, the show Seinfeld. So Seinfeld, to make it short, Seinfeld did a show about dating a dermatologist. And when he said that, they would go to dinner and the girl would say, yes, it's wonderful. She was a woman dermatologist, and she'd say, it's wonderful saving lives. And so he had a whole show about an interaction, saying, what does she save lives? What does she save lives? She doesn't save any lives. And then they go to dinner, and a guy comes up, of course, and he's about to say to her, you didn't save any lives. What are you talking about? All you do is see acne. And a guy comes up and says, oh, doctor, you saved my life. You found that melanoma. And then his whole date was no good after that. So the point is that finding these things early do save people's lives. I had a gentleman in the other day said, you remember that melanoma you found? Yes. We found it on his back. He had no idea he even had a mole there. It was a melanoma. It was thick. It was somewhat advanced, but not metastatic to lymph nodes. We caught it just in time. And who knows what would have happened to that gentleman had we not been able to see that. So, and medical literature is replete with doctors finding these things, but relatives finding these things, and friends. So suggest it to people. You were here at the talk, somebody says, what'd you do today? Say, I went to skin cancer talk. And they say to you, well, what'd you learn in there? I learned that if you have something changing on your skin, you better go see the doctor. Well, I have this little mole in the back of my head. It's been under my hair, and I didn't realize it was changing. Go to the doctor. I have this thing on my back. Go to the doctor. And get it checked. It never hurts to do that, and it might save their lives. So, any questions?